men are more likely to have symptoms than women. Men are more likely to have severe symptoms than women. And men are more likely to die from COVID than women, significantly so. We see some differences in parishes, but we suspect it may be due to some investigation. So, for example, St. Elizabeth have more mild symptoms, are more likely to have mild symptoms than the other parishes. But when we look at it, it's not so for the moderate and more severe. I think St. Elizabeth team is just a little bit more on the ball in getting us the data. So we're able to pick up the mild symptoms, but for the rest of the country, you're going to get the moderate and severe. So we're looking at those sort of data a little bit more keenly.
Coming now to the comorbidities, if you can give us a breakdown, for example, of the comorbidities and the case profile, whether through active cases or recovered cases, as well as death-related cases.
The easiest one to do is deaths, really, because we have the more complete data set for deaths and for persons who have died. So 93% of persons who died had one or more comorbidity or a risk factor such as age. So 71% were 60 years and over. 53 had cardiovascular disease, with hypertension being the main cardiovascular disease. 41% had diabetes. 9% had renal disease. 5% had cancer. Another 5% had some neurological condition, and 4% had asthma. We also had in the top list obesity and chronic smoking. Chronic smoking. For every case that we have, we do a contact tracing. And then when we looked at possible transmission scenarios, so we would have a sister who, probably that's not a friend who lives X, they're sick, they call the friend to carry them to the hospital, and then that person, that's the only interaction they have had, that person comes down with COVID-19. So, or we have done contact tracing for somebody, trace them back to the bus driver. The bus driver came back positive. The person sat in the front with the bus driver. The bus driver came back positive. So what we do is look at how many persons were listed as contacts in a vehicle and compare it to like the family situation where you might have 5-6 persons household contacts.
How does 9 months later, how does the forecast change for example, the number in the population who will contracted? I know we've given out this huge figure in July or June thereabout or something.
March.
In March, right. Where it said that up to 1 point something million or whatnot. What are the new figures in light of the latest data that we have?
So as I said to you, we get the tip of the iceberg, because that prediction was based on an influenza model and what happened in 2009, and we looked at the differences between COVID-19 and influenza A H1N1 pandemic strain of 2009. So we looked at the differences, and we did a prediction based on how this moves throughout the country. The thing about it, That's per year. It may still happen, but there are interventions that have happened along the way, so it may be different. So we have almost 12,000 confirmed cases, which may mean probably 10 times as many cases or more. So, and with so I'm praying we don't reach there. There's the intervention with the vaccine, but everything is still possible, and it's based on how we keep the protocols and how well we maintain at least a sufficient level to prevent increased transmission, because it can, and we have seen what happened in August into September. You know, it can just increase if we relax the measures. About 8% of our cases are children. That's persons 0 to 17 years. We have had deaths among children. All had comorbidities, but they have had the lowest death rates.
Why?
I'm actually not sure, but when we break it down further to like under 5, there is a little difference, which we would expect of a slightly higher number there. But overall, this disease seems to be, in our population, affecting the older persons with poor outcomes and the persons with comorbidities and the men.